MSF just said out loud what we've been circling all week. Testing is still the soft spot in this response. If you're just joining us, DRC's Bundibugyo outbreak was under strain before any of this. It was recognized late, lab capacity was uneven, and contact tracing was stretched. Earlier reporting found gene expert machines in Bunia missed the rare circulating species. That cost teams about a month before Kinshasa testing confirmed Ebola Bundibugyo, leaving them to reconstruct transmission after the fact.
This is Ebola Watch. Today, MSF goes on the record about the testing gap, a new CDC entry restriction with a surprise country on the list, and what intensifying surveillance actually looks like at a border crossing. Sarah, let's start with the warning. We're staying on DRC Bundibugyo Ebola outbreak. Follow the show, and you won't miss what comes next.
From ReliefWeb.
As of 15 May, a total of 246 suspected cases and 80 deaths, 4 deaths among confirmed cases, have been reported from Rwampara, Mongwalu, and Bunia. 24 suspected cases are currently in isolation facilities across the 3HZ.
The May outbreak now has a formal designation, glide number EP 2026-000071 COD, status ongoing. In plain English, the international humanitarian system is filing this under a tracked disaster code, as well as a health alert.
So it graduated. For anyone who's been following this as a health emergency, it's now a coded disaster event, with 8 confirmed Bundibugyo samples and a glide number to match.
And keep the 2 columns separate. 246 suspected cases, 80 deaths. But only 4 of those deaths are among confirmed cases. The confirmed and the suspected don't collapse into one scary number.
Right, and the strain matters here. This is Bundibugyo, no licensed vaccine, no specific treatment. Per ReliefWeb, the last 2 Bundibugyo outbreaks had a 30 to 50% fatality rate.
Which is exactly why early supportive care is the lever. There's no dose to ship, so diagnostics and bedside care are where this response lives. And that's where the strain on testing starts to bite. From CDC.
CDC has temporarily restricted entry for certain travelers who are recently in DRC, South Sudan, or Uganda. Travelers should follow after travel recommendations until 21 days after leaving an affected country.
Okay, here's the concrete one. CDC's Traveler View page now says they've temporarily restricted entry for certain travelers recently in DRC, South Sudan, or Uganda. It moves this out of pure advisory territory and into border control.
And note the geography, Daniel. South Sudan is included in the restrictions, but it hasn't been on the outbreak map so far. So its inclusion points to proximity and movement rather than confirmed transmission.
Right. So for the parent with a kid at a field post, what changes today? The 21-day after-travel monitoring window. You follow the recommendations until you've been out of an affected country for 3 weeks.
And the page still has Level 3 for non-essential travel. Level 2, enhanced precautions. Level 1, usual. 3 tiers stacked on one country. The restriction is the new top layer on an already layered notice. Here's Charity Kiley at the Eastleigh Voice.
Doctors Without Borders, MSF, has warned that testing remains one of the biggest weaknesses in the response to the Ebola outbreak in the Democratic Republic of Congo, DRC, despite recent improvements in laboratory capacity and the deployment of hundreds of mobile testing kits in eastern DRC, limiting efforts to detect and contain infections early.
MSF put it on the record yesterday. Kate White, their emergency medical coordinator, said the outbreak is moving faster than the response. The line that matters? Testing remains one of the biggest weaknesses, even with the lab improvements.
Right, that qualifier. Despite improvements. The machines and the mobile kits showed up, hundreds of them, and the gap's still there.
Which tells you the bottleneck isn't only hardware. White says even the relatively stable areas are dealing with weak case detection, limited testing capacity, and not enough contact monitoring. The Ituri centers are straining.
And that connects to the death toll. Over 180 now per AFP, more than double the 80 at the May 15 declaration. If you can't test fast, you can't isolate fast, and the chain keeps moving.
That's the cost of a missed test. It means a confirmed case can spend days counted as suspected, infecting contacts nobody has mapped. This one's from Minnesota Department of Health.
Obtain a detailed travel and exposure history from patients with an acute febrile illness, especially those who have been in affected areas in the Democratic Republic of the Congo, DRC, and Uganda within 21 days prior to symptom onset, while also evaluating for more common causes of febrile illnesses.
So here's the one that actually touches a listener in the Midwest. Minnesota's health department put out a clinician advisory. Detailed travel history, 21-day window, private room with the door closed, call MDH immediately.
And notice the discipline in the language. Reconsider non-essential travel to the DRC and counsel on prevention for people who are already going. It's a clinical screening protocol, not a panic memo.
Right, but for the parent of a returned traveler, what does this actually mean? You come home with a fever inside 3 weeks of being in an affected area. Your urgent care doctor is now supposed to ask where you've been before they reach for the usual suspects.
Exactly. And the advisory still says evaluate for the common causes too. Most febrile travelers have malaria or the flu, not Ebola. That balance is the whole point. Catch the rare case without terrifying the typical one.
Which lands differently after the MSF piece we just hit. The detection net depends on testing, and MSF says testing is still the weak link. The advisory tells the clinician to flag it, but the flag goes into a system that's already strained on confirmation.
That's the connection worth making. A 21-day screening window only works if a suspected case gets confirmed quickly. And the confirmed versus suspected gap is exactly where that pressure shows up.
When officials say Uganda and DRC are intensifying cross-border surveillance for Ebola, what does that actually look like on the ground? And how can it reduce risk without simply closing the border?
So, short answer, it's layers. A border closure is the blunt end of the spectrum. On the ground, Ugandan authorities deployed more security and health personnel at official crossings like Mpondwe Lubiriha in Kasese district and the Busunga border point in Bundibugyo district. Per reporting from Kasese, that also means patrols along unofficial crossing points, alongside the formal gates. Anyone authorized to cross, and Uganda did keep the border open for humanitarian operations, food cargo, and security convoys, has to go through health screening, fill out a locator form for contact tracing, and submit to ongoing monitoring, according to the Ugandan Ministry of Health. Then there's the coordination layer. In late May, health ministers from DRC, Uganda, and South Sudan, alongside WHO and Africa CDC, met in Kampala to align on a joint cross-border response framework. And by mid-June, officials from both countries had wrapped a follow-up 2-day meeting in Aru town to finalize a joint Ebola response plan covering surveillance protocols and information sharing. That last piece is what makes screening useful. A positive screen at a Ugandan checkpoint only matters if DRC health authorities hear about it quickly enough to trace contacts.
Uganda did eventually move to a fuller border closure, though. So what's actually still getting through? And is the locator form system realistic when traders have perishable goods rotting at the crossing?
That's real tension, and it's documented. Reporters on the ground in Bwera found traders watching plantains and fish spoil in stalled convoys, and that creates pressure to look for unofficial routes that skip the health screening entirely, which is the last thing surveillance needs. The authorized exemptions carve-out, humanitarian, food, cargo, security, is supposed to keep that pressure from overwhelming the system, but it only works if the locator forms are actually processed and followed up on. Next, listen for whether the joint Ebola response plan produces a functioning joint alert mechanism, because coordinated real-time data sharing between Kinshasa and Kampala is what turns a checkpoint form into an actual contact tracing lead.
If you're following Ebola Watch for clear outbreak updates, you might also like Hantavirus Watch, daily updates on the 2026 outbreak, including the MV Hondius Andes virus cluster, CDC and WHO response, contact tracing, and traveler risk. Find it wherever you listen to podcasts. You'll find links to every story we covered today in the show notes, so if one caught your attention, that's the place to go deeper. That's Ebola Watch for today. This is a Lantern podcast.